PowerPoint. Okay, got it. Let's see. Switch to screens. Share. Yeah. Hi, I'm Williamini, and I'm a undergraduate biomedical engineering student at Stony Brook University. Like throughout the past few years, we all have been experiencing the COVID-19 pandemic. There have been many different variants of concern, each of which have had a more successful mutation that made it more evolutionary advantageous for it to go and replace the previous one. I'm going to walk you through of some drug discovery and vaccine development applications for this, because like even if you're not interested in creating this type of research or not creating vaccines and drug development, and you still need to know this if you're going to become doctors. Vaccines and drugs are bread and butter of most medicines nowadays. So let's begin with basic drug discovery. There are many different types of drugs used. You could have biologicals, such as antibodies. You could have natural products, some variations of whether it's derived and then chemically synthesized again separately once they come up with a chemical sequence and do an organic chemistry reaction sequence for it. And then you could also create drugs from scratch through virtual screenings. And you could go and see that let me get my laser pointer on. And the proportion of human protein drugs is becoming quite high. And small molecule drugs are like much smaller than proteins, where you just have like a tiny molecule that could go and inhibit something, whereas with protein drugs, you just have like a larger protein that could act as an inhibitor. Drugs work through a lock and key model. You have the outer part shape of the receptor, and then you have the drug itself. Like you could see all these lines, stick figures, and then you could see this clouding stuff, the clouds symbolizing the electron cloud that goes and shows you kind of like the general shape of like all the electron orbitals, whereas the sticks kind of just show you the general structure from an organic chemistry standpoint. There are several key terms I would want to go and cover. For drug discovery, the target is a biomolecule that interacts with the drug. A lead is considered the base molecular structure motif of a developed drug. It's like the most general shape that's used to go in this refined and made much better. The head's kind of like from the compound with after initial screenings. Then they start selecting some more compounds to go and test. And then you have then you go and actually start testing them in animals for efficacy and then the activity and to determine the dosages and whatnot. That kind of like highlights the key concepts of rational drug design, where you have all of what I talked about is literally here and here. Then you have all the clinical trials, then you have to go through a huge FDA review process, and then you have to continue monitoring the effects of the drugs many years after. A lot of the molecular docking virtual screenings are based off of statistical mechanics. I know many pre-meds do not enjoy physics courses. However, like once you really do need to know physics for medicine, you could talk about blood flow in hearts. You could talk about how someone walks, or like mechanical forces. But here we're talking about electrostatic forces through statistical mechanics to minimize the global free energy. And that's what optimizes all the drug bindings. In theory, you could also apply this to any type of antibody discoveries as well. Any type of molecule that you want to optimize, you do it this way. Drugs build upon previous drugs. For example, you have an HIV protease here, and then you have SARS-CoV-2 protease here. You can see how they are very, very similar in structure. Like this entire part here is almost the same as here, except you don't have an OH group, but you have an oxygen group, and then everything else is slightly different. Instead of now, I'm going to be talking about this more specific class of drugs called nucleoside and nucleotide analogs. Here we are able to go and see the standard adenosine, guanosine, cytidine, and uridine molecules. These are the AUCG molecules from RNA. In RNA, we have a U as opposed to a T in DNA. These drugs act, nucleoside analogs. Hold on, sorry, I'm getting a phone call and I have to go and just stop that. The nucleoside analogs are able to go and act as an inhibitor when the viral replication process. These are the current molecules that are used during normal replication. And then there are many different modifications that can be made to go and be able to prevent the replication. You could change a hydroxyl group, you could add more sugars, you could change the ring size, make it from a 4-carbon ring with 1 oxygen, make it a 6-membered ring. You could phosphorate it there. Ring openings, closings, many more times. Here's an HIV drug where you're able, you could go and see of how instead of having this part here, like that's the standard base, you have this instead, where you are missing these 2 hydroxyl groups, and that's able to go and prevent the replication, transcription there. And now you have something similar used for COVID. You probably have heard of this drug and this drug here. Both of all of these are nucleoside analog inhibitors. These I'm not really talking about, but I'm just wanting to be able to show you how many. We have 12 different types of drugs used that for COVID that have a similar mechanism as this. Now, vaccine development. There's 2 types of immunity: active and passive immunity. Active immunity is developed in response to infections or vaccinations, whereas passive immunity comes from somewhere else. Like an example of passive immunity could be you're just getting an antibody treatment injected into you. Or if you're a baby and you're able to go and get your mother's antibodies through breast milk or through the umbilical cord before you're actually born. Active immunity is where you have your own body creating an immune response. Like antibodies respond to a vaccine. Antibodies respond to an infection. And vaccines are an artificial type of immunity. This just shows the same, what I said before, in a tiny bit more detail. If antigen-presenting cells show the antigens from a pathogen, and those recruit cytotoxic T cells and B cells. B cells produce the antibodies, T cells go and are able to go and kill the cells. Antibodies are like an inhibitor where they actually block or bind to, for example, to the part of the protein that infects the cells. For example, if you're talking about SARS-CoV-2, it would go and bind to the spike protein to be able to go and block it from binding to the ACE2 receptor. And we could just see the timeline of how when you have the peak antibody levels, IgG is the most common, and we are really concerned about that for vaccinations, but you also want to go and consider the IgM ones as well. There are many different types of antibodies, but IgG is the most common used for monoclonal antibodies. There's different types of vaccines out there, like RNA vaccines, inactivated live attenuated protein subunits, virus-like particles, replicating non-replicating viral vectors, and bacterial vectors. protein subunits are like where you are similar to the virus-like particles where you have, say, the spike protein decorating an outside of a capsid, but you don't have any of the genetic material inside. You are only responding to an antigen. Nucleic acid vaccines, such as RNA vaccines and DNA vaccines, are like the ones used by Moderna and Pfizer for COVID. And you're going and producing the protein subunits inside your own body as opposed to having it be produced outside the body. Then you have inactivated and live attenuated, where you actually still do have the viruses or bacterial's genome inside of you. Live attenuated is where you can like weaken it, but where inactivated is where you actually kill the virus. And that's kind of like results in typically a lower efficacy than live attenuated. And these just give some examples of all the different companies that use all these different types of platforms for SARS-CoV-2 vaccines. All of these vaccines produced in the United States use a double P mutation, a double proline mutation to help stabilize the spike protein. The spike protein is very, like, has this receptor binding domain that acts like a hinge web. It starts like this and then it folds downward like this to get to that state. This state is not good for being able to recruit antibodies for vaccination. This state is. So they needed to come up with a mutation that forces this conformation and prevents the spike protein from rearranging to this conformation. And there are many different ways to do that. Double P mutation inducing salt bridges, cavity filling, and disulfide bonds. Here, you're going to see 4 different locations of the double P mutation. And I would like to go and point out that the mRNA vaccines have the highest efficacies against infections. These are like a table that's a year old, but so they do not include a new bivalent booster, but they are same style as these two here and have similar high efficacy rates for the current Omicron strains. One simple project for my research was to go and do or check for sequence homologies between HK, COVID proteins, and C1q. C1q is part of the classical complement pathway and is involved in thrombosis through bradykinin. This leads to the typical SARS-CoV-2 lung damage. You have a lot of swelling and edema in the lungs. ACE2 is a receptor for COVID spikes, but it's also used to be able to break down bradykinin. Because the SARS-CoV-2 spike protein binds to it, that there's less ACE2 receptors available to break down bradykinin, which is able to go and lead to edema, swelling in the lungs. I won't advance. This is a general COVID pathway where you have infects, binds to the ACE2 endocytosis. The virus comes into the cell, you release a genomic RNA, and it replicates. You get the proteins, it assembles into vesicles, and it exits. I'm not going to go through that because I have a few more slides I want to get through by time frame. But there's no going back to the homologies. There's very little homologies between them, which is a little surprising because you would have expected there to be homologies between them. But and I have some results in a few slides later. A few slides are out of order. I'll show them once we get to it. Here's the SARS-CoV-2 genome. You can see that there's many different molecules besides the spike protein here, the envelope protein, the membrane protein, and the nucleocapsid protein here. Like the 4 purple ones are structural proteins involved, and the rest of these are more accessory proteins, non-structural proteins, where you like would recognize a helicase perhaps. polymerases and whatnot, which are needed to go in for the viral replication. Here I'm presenting you an article that came out of Columbia University where they were able to actually be able to predict the location in the SARS-CoV-2 genomes where there would be a lot more conservation and mutations. And then I was able to just go on a different project I worked on was where I just simply wrote code that wrote other code that was able to go and do high throughput tagging of all different mutations among many different coronaviruses. I got many different images that look like these. This is the N protein in humans. And this is the spike protein. The others I'm not showing. This really just shows the ACE2 receptor bindings. Then my advice for anyone who's pre-med is just get into a research lab. Research is very highly valued in your application. And if you find out that you really enjoyed research as well as you're still interested in medical treatment, being a physician, then you could always consider medical scientist training programs called MSTP. They are NIH funded and actually pay for your med school tuition and pay for your PhD. That would save you hundreds of thousands of dollars. Like, even if you don't want MSTP, getting involved in research helps you get to know the PI. You get a lot of mentorship through that. And that will obviously also help you with the applications where you get additional letters of recommendation and have more experience. That should be it. Any questions? I'm not able to go and see. Okay, there's no questions in the chat, so.
If anyone has any questions, you can go ahead and like unmute yourself and ask, or ask in the chat. And if not, I have questions already that you guys asked me, answer the Google form.
I think you could start with the ones in the Google form and then we'll keep checking the chat.
So someone asked, what did you begin in high school that was related to pre-medicine and like helped you get into shadowing yourself?
Well, I was part of an advanced science research group in high school that got me involved with Cold Spring Harbor projects, and so that really just helped me get into research in general. I did not really have any shadowing in high school, but as part of my graduate program in biomedical engineering, I had like 10, 15 hours of shadowing so far, where I've observed many skin level surgeries, totally unrelated to vaccine development and drug discovery, but it was very amazing being able to go and watch many of the surgeries. I know it's difficult during COVID, but most doctors will want to go and be able to go and help share knowledge and help give experiences that would help. There'll be a new generation of doctors to go and replace them.
What was the hardest time that you've experienced in your medical journey, and how'd you overcome it?
For my hardest experience would have actually been struggling with biochemistry as an undergraduate. It was asynchronous, and I really just don't really do asynchronous courses well. And I ended up having to go and repeat that course, but I repeated it over the summer, smaller class size, and I did much better. And then I took graduate biochemistry as well, and did well in it as well. So that really would help go and show that I ultimately did learn the biochemistry. And also having a high MCAT score could help make up for any of that.
I know a lot of people get like really anxious about having the possibility of having to retake a class. So would you say that retaking your biochemistry class was better for you than just doing it once?
Um, yes, because I decided to use a grade pass no credit option in my school. So I literally had a pass on my transcript. So that really would not be interpreted well, and especially going to have, like if you have anything like get a P on your transcript for passing, and you don't have a letter grade, that would automatically be interpreted as getting a D on your transcript. At that point, you need to go and retake it. It's not going to count for your major, or it's not going to count towards your pre-med credits, and you need to go and want to go and show competency in it. Get a grade of like a B, B plus afterwards. If you were to go and have a pass or withdrawal on your transcript, and that's something I did. Like it's not great, but it's the alternative of not retaking it would look even worse. Like I don't really know what else to go and say for that.
Okay. Another question somebody asked was, did you have a light bulb moment when you knew you wanted to be a doctor or do medical research or anything like that?
Well, I was always interested in research, like going back to when I was taking my first high school level biology course. We were covering the biotechnology and viruses chapter in the cancer bio chapters in Campbell's biology textbook. I'm sure many of you have used that textbook in introductory bio chapter like 2021, 22, somewhere around there for the biotechnology. And that I found that fascinating. That's why I chose BME, because I'm interested in genetic engineering, biotechnology, and therapeutics. And then I had some different other talks I went to as a freshman in undergrad, like where I was exposed to HIV research. I got a talk from someone who saw HIV under a microscope before they even knew it was actually called HIV, which was just amazing. Getting other talks about HIV and extracellular vesicles as well was from someone who's now a dean at New York Medical College. Used to be who was at Stony Brook before. That was also amazing as well.
It's nice to know. So, it is 11:30 and our next speaker should be here soon, but one last question
Okay.
is if you could do something differently as a student, what would you do?
I would have started doing office hours a lot more. Stay on top of the course. Office hours should not be used as a drug. They should be used as a vaccine. Be proactive. Get to know the professors. Work with the TAs. They will help you, especially if you're like even if it's in a large class, such as Orgo. I did Orgo online. There were like 30 different TAs for that course, my section alone. They ran amazing review sessions, and they're the reasons why I got through Orgo. Don't overload courses. It's better to go and take 5 years to get through a pre-med curriculum and have like a killer GPA than get through it in 4 years and have like say a 3.5 or 3.4 GPA. No more than 2 or 3 hard science courses a term. Do not take anything not needed for your major. And if you are an biomedical engineering student, please be careful of when you take pre-med courses with engineering courses such as electrical circuits and fluidics, solid biomechanics, differential equations, multivariable calculus. All those are very demanding courses and will go and probably demand more time from you through written assignments than a course like biochemistry or organic chemistry, where it's just exams. Make sure you just review everything on a daily basis or every other day. Don't pay attention to the textbooks as much as because that takes too much time to be able to read the textbook thoroughly. Just skim the textbooks, look at for any key headings, look at the summaries, at the end of the chapter and preview the lecture notes that if they're posted ahead of time on Blackboard or Brightspace or whatever other platform your school uses. Just go into class prepared ahead of time. Know something about the topic before it's taught. So you're not just, what am I seeing? It's like, okay, here's this point I was confused about, and this is what the professor's explaining now. That makes it easier. That's it.
Okay, that's all really good advice. So thank you for your time today.
My pleasure.
Thank you again, William, for your time, and we really appreciated you speaking here today, and I'm sure that we've learned a lot. And our next speaker is Carol. I'm not sure if she's in here right now. I'm not sure if she has like a different name for her username. So if Carol is here, we'd appreciate if you unmute or let us know that you're here. Otherwise, I will make sure with her that she will be attending. Okay, we've emailed the second speaker, and I think we'll wait until 11:45 at the latest to see if she comes. She did let me know that she was going to, I think, yesterday or 2 days ago, but hopefully that she replies to my email. If not, we might have to move on to our third speaker.
So we're we're still waiting on our second speaker, but we're just gonna go ahead since our third speaker's here. We don't want to keep her waiting too long. So we're just gonna go ahead and start with our third speaker, and then if Carol shows up at the end, she can give her presentation also. So with that being said, our third speaker is Nav Kern. I'm sorry if I pronounced that wrong. So she is a recent UCR graduate and she majored in microbiology and minored in anthropology. So you can go ahead and start your presentation now.
Hi, thank you for the intro. I wanted to ask, how much time do you guys have if Carol does not show up?
I think you can go as long as you need to, but the
Okay,
meeting is set to last until 1 p.m. EST.
got it. Okay. Okay, cool. So I'll go ahead and start. So, I think your name's Bethel. Like she introduced me, my name is Nav Kiran. I'm a recent graduate of UCR, and that's a university in California. I think you guys are on the other coast, so that's pretty cool. And yeah, I majored in anthropology, or no, I majored in microbiology and a minor in anthropology while I was in undergrad. And I did a lot of high school outreach for health education. So I'm recycling this presentation, but hopefully it will be helpful for you guys. And I'm focusing on cardiovascular disease and stroke in minority communities. So this is what we'll be covering today. And we'll first be covering the basics of cardiovascular disease and stroke. So when we're defining cardiovascular disease, I think we all know it's also known as heart disease, and it describes a group of conditions that affect your heart and blood vessels. And so there are a few different forms of cardiovascular disease, including heart attack, which includes a blocked blood flow to the heart, which causes heart damage, and then the heart attack itself. Heart failure, which is where the person may have a weak heart and not enough blood can be pumped, which then leads to oxygen not being sent throughout the heart and the body itself, and that causes heart failure. And then we also have arrhythmia. And arrhythmia relates to an improper rate or rhythm of the heartbeat, and that usually relates to an imbalance in the person's electrolytes. That's something to consider. Okay. So something to note is CVD is an umbrella term. So what does this mean? This means that there are multiple forms of diseases and conditions that fall under the term cardiovascular disease. So as we can see here, we have congenital heart disease. There's also a deep vein thrombosis, pulmonary embolisms, cerebrovascular disease, peripheral arterial disease, rheumatic heart disease, and coronary heart disease. So all of these are like different in their own ways, but they relate to the heart not being able to function normally. So when we take a look at the stroke, we can see that the stroke is also known as a brain attack. And it's a type of CVD that happens when the blood supply in your brain is blocked or disrupted. As a result, your brain can't get enough oxygen or nutrients it needs, and it leads to brain damage and tissue death. So when we look at the different types of stroke, we can see that there are two main types. There is the hemorrhagic, which is where a blood vessel ruptures in the brain and then causes tissue damage or tissue death, and the ischemic. This is where there's a blood clot or plaque, which then blocks blood flow to the brain and causes tissue damage or death. So both of these types of stroke are quite similar, but we can see from these diagrams that with the ischemic stroke, there is the blood clot that is caused by plaque. Okay, and then something to consider when like you're facing an emergency. So for background, my dad actually had a heart attack, and I was like 10 when I saw that happen. So from like a young age, I know like how scary it is to be around someone who might enter an emergency health event. And, it's important to understand what can you do for first aid and what can you do to like make sure they get the help they need. So in this case, this is why the acronym BFAST exists. And this mainly applies to stroke. So we all know that in like a health emergency, you should call 911 if someone's experiencing any like abnormal events. So the first key to consider is balance. So this means that you want to consider, are they dizzy or are they clumsy? So in this case, you want to think about like, maybe are they losing balance, or do they have a lack of coordination? When looking at their eyes, you would want to see if their vision has changed in any way. So is it suddenly blurred? Do they have a double vision, or can they just not see in both eyes? When looking at their face, you would want to make sure that both sides are equal, right? So in this case, you would want to ask them to smile, and you would check if either side is drooping in any way. When looking at their arms, another key is to make sure that they can raise both of their arms. And, if they can't, then that's a possible sign of numbness or a blockage as well. And then in terms of speech, you can ask them to repeat a short phrase. And if they slur their words or they can't speak clearly, that's another warning sign. And time. So in all emergency events, time is very important. So this is why you have to make sure that you can call 911 or go to the hospital as soon as possible if any of these signs occur. So this is one sign of stroke. So we know that facial paralysis is a common sign. So as you can see here, this woman, half of her face is now paralyzed. Another uncommon sign that isn't really talked about is a sharp or abnormal headache. That's a common sign I've seen in like some of my family members that have had a stroke. And usually they have this abnormal headache or head pain, and that's also a sign. So again, if you or anyone you know might have these symptoms, you would want to call 911 as soon as possible. Okay, so now we'll focus on health disparities. So what is a health disparity? A health disparity is a difference in healthcare quality, not necessarily related to access, preference, or intervention. Patients, providers, and healthcare systems all contribute to health disparities, and this includes the individual behaviors in regards to diet, exercise, and genetics, along with provider biases and unfamiliarity, as well as systematic issues such as coverage and cultural competency. So when we look at minority groups themselves, we can see that overall, when we look at minority groups, there is a higher chance of developing cardiovascular disease. So specifically, when we look at Black or African American communities, there is a overall 2 times higher chance of developing stroke when compared to people of the white community. Along with there being an increase in rates of heart failure and higher death in general from CVD. And there's also a 40% more likely chance to have high blood pressure. And I think, as most of us know, high blood pressure is the leading cause of cardiovascular disease. When we look at non-white Hispanics as well, there's an increased chance of heart failure. And there is also, in general, a lack of CVD awareness. So this means that in the non-white Hispanic community or the Latinx community, there is a lack of education in terms of health. Lastly, there's a higher chance of diabetes and a increased chance of high blood pressure as well. So something to note here is also when developing diabetes, specifically type 2 diabetes, there is then a higher chance of developing cardiovascular disease. So it's important to not develop diabetes in the first place because it can lead to other diseases as well. And then when we look at the Asian American and Pacific Islander community, we can also see that CVD issues occur earlier in life. And South Asians exhibit non-traditional CVD risk factors. There are also lack of proper screening for CVD. And there's also a very high smoking rate in the Pacific Islander community, which leads to CVD. When looking at prevention in terms of the African American community, it's important to increase stroke symptom awareness, to know when, where, and how to intervene and help, and to understand the benefits of tailored heart drug treatments. When looking at the Hispanic community, there should be, like I said before, increased CVD risk awareness, a greater understanding about diabetes, and a greater understanding on how to combat obesity and high BMI rates. And with the Asian American Pacific Islander community, it's important to screen earlier in life and to avoid smoking or decrease smoking, and to increase awareness regarding non-traditional CVD factors. Okay, so now we'll look into risk factors. So, like I think most of us know, some risk factors for CVD includes high blood pressure, and it's important to note that HDL is good cholesterol, whereas LDL is bad, right? So usually you want HDL to be higher than LDL, and LDL should be less than HDL. But in general, both cholesterol levels should be within range. And like I said before, diabetes does lead to cardiovascular disease, so it's important to prevent the development of diabetes and prevent obesity. So when we look at lifestyle, it's important to not consume a lot of alcohol, saturated fat, trans fat, cholesterol, and sodium-rich food. And you should be exercising to not only, like stay fit, but to also keep your heart muscles strong. And lastly, you should limit tobacco use. In terms of factors that cannot be changed, this includes genetics. And so as we know, genetics are, they kind of relate to diseases that are passed through genes. So an example of this is how CVD is actually it's kind of considered a hereditary disease in certain families. So like in the South Asian community, CVD is very common. And then some other factors include your environment and occupation. So this is where it's important to consider how where you live can affect your health. So, like when you consider toxic substances, and then when we think about race and ethnicity, the leading cause of death in African Americans, American Indians, Alaska Native, and white people, as well as Asian Americans, Pacific Islanders, and Hispanics. For all of these people, CVD is a leading cause of death. Okay. And then again, so this is a review of risk factors for stroke. So again, high blood pressure, heart disease, diabetes, obesity, a history of transient ischemic attacks. So this kind of relates to your heart. I believe it relates to heart attacks. And then having a high red blood cell count, high blood cholesterol and lipids. This relates to accumulation of cholesterol and lipids. This then can lead to plaque development and can then, like we saw earlier, lead to stroke. And then lack of exercise is also a risk factor, as well as excessive alcohol use. Okay, so some other risk factors include being older, right? So after 55, you're at an increased risk for stroke in general. Like I said, race. So at most, African Americans are at the highest risk for death from stroke. And in terms of gender, more men are likely to get stroke, but with women, since symptoms are usually different from men, women tend to die more from stroke. And then in terms of other risk factors, if you do have a history of prior stroke, you're likely of developing stroke again, as well as again, having the genetics where stroke is common in your family. And then, like we said before, your environment counts as well. And lastly, when you're looking at socioeconomic factors, people of a low income are at a higher risk of stroke. So then I wanted to make this a bit more interactive, but why do you think people of a low socioeconomic background are at a higher risk of stroke?
Did I try to guess?
What was that?
I think that maybe they could be at a high risk of stroke because earlier you said like the certain types of fats, like low income people might not have the choice to eat healthier food, so they might like have a high risk of stroke.
Exactly. Yeah. So this is where you want to consider like what do you have access to? What types of environment do you live in? And also stress, right? Stress is a huge factor for developing stroke and heart attack. Okay, so moving on, we'll look at prevention. So strokes and CVD is preventable. Give me 1 minute. Okay, so how do you prevent cardiovascular disease? So like we said earlier, don't smoke or use tobacco. Cigarette smoke reduces the oxygen in your blood, and this is why smoking is the leading cause of death when developing cardiovascular disease or stroke. Limit alcohol consumption because excessive consumption leads to weight gain, which increases the risk of CVD. And you should get regular health screenings. This is very important because with regular health screenings, you're able to see where your overall health is. And most importantly, when looking at preventative health, health screenings are the #1 key in preventing cardiovascular disease and diabetes itself. So health screenings is very important. And other things like having access to insurance is also incredibly important. So engage in healthy habits, manage your stress. Stress is the #1 cause of developing cardiovascular disease and stroke, along with developing blood pressure. Manage pre-existing conditions such as diabetes. High blood sugar levels can damage your blood vessels and nerves, and eat healthy and exercise. So an example is the DASH diet to follow. And we should know that 80% of strokes are preventable. How do you prevent a stroke? So #1, like we've been saying, lower your blood pressure. High blood pressure is the biggest contributor to the risk of stroke in both men and women. Test for atrial fibrillation and get treated. Atrial fibrillation essentially relates to how well does your heart beat, and it does the electrical circuit of your heart work correctly. And if it doesn't work correctly, then this can result to an irregular heartbeat that can then cause clots in the heart. And again, you need to stop smoking. because plaque can accumulate as a result of smoking. Okay, so I know we're kind of short in time, but just a little quick quiz here. So aside from what we brought up, what other factors do you think might contribute to stroke and CVD? So I guess there's like two answers. So one of them connects to mental health, and the other one connects to key elements in your body. Okay, and then if no one wants to answer, it's okay. So the first answer would be anxiety disorder. So like we said, people who are more prone to developing anxiety can then develop high blood pressure. And as we know, high blood pressure is the #1 cause of CVD. So definitely take care of that anxiety disorder. Yeah, diabetes is also another cause. Diabetes is the I guess like the root disease, which then leads to development of CVD. And another one is also making sure your electrolyte balance is on point. I feel like this isn't really talked about enough, but if you don't have the proper amount of like sodium, potassium, and chloride in your body, this can affect your heart as well. And this can lead to stroke. Okay, and then the next question was one lifestyle change someone can make to prevent CVD and stroke. This can be exercise, maintaining stress, and having a good diet. All right, so case study. So this is our case study. So first we'll review medical history, symptoms, diagnosis, and treatment. All right, so when we're looking at this patient has been diagnosed with type 2 diabetes, and they're currently medicated with metformin. This is in 2011, and in April 2014, they were diagnosed with hypertension or high blood pressure, and they're currently medicated with beta blockers. In October 2014, the patient was admitted for prolonged chest pain. So for background, this patient is 50 years old, and she lives in New York. So what we know is this patient is taking metformin, and that's to take care of their type 2 diabetes. And they're also taking beta blockers, and that helps dilate blood vessels. So let's take a little further look. Okay, so since we know type 2 diabetes can lead to developing CVD, it's important to consider what types of medications the patient currently takes. So in terms of metformin works by reducing the amount of sugar your liver releases into your blood, and it also makes your body respond better to insulin. Insulin is the hormone that controls the level of sugar in your blood. It's best to take metformin with a meal to reduce these side effects. And so as you can see here, metformin itself, even though it targets insulin resistance, it does affect your body in other ways, right? So we can see that it can impact your gut microbiome, and it can also impact other parts of your body. And it can lead to other things. Okay, and again, when we're looking at metformin, there are different processes that occur with metformin and how it impacts your body. So there's this thing called gluconeogenesis, which kind of relates to the development of glucose, and so it decreases that. And then we have lipogenesis, it decreases that. So lipogenesis is essentially the creation of fat. And so as you can see here, it decreases that. So in this case, it is good because patients who take metformin tend to see a increase in weight loss, but it's usually like severe weight loss. So it's very drastic. And then obviously we can see here that metformin does improve insulin sensitivity, and thereby it kind of reverses the damage type 2 diabetes makes. So yeah. And yeah, so it affects your muscles, your liver, your pancreas, fat, how is fat developed, and then how is glucose used in your body. And then again here, I thought this was important. So, in terms of type 1 and type 2 diabetes, with type 1 diabetes, it's usually developed early on. This is kind of irrelevant, but I just wanted to make this kind of clear. So type 1 diabetes is developed early on, and it relates to a insufficiency in insulin. Whereas with type 2 diabetes, other factors such as obesity and genetics lead to the development of type 2 diabetes, and it essentially relates to your pancreas not being able to secrete enough insulin because your body has developed insulin resistance. So that's something to consider. Okay. And then when we're looking at the other medication the patient takes, they're taking beta blockers, right? So beta blockers work by blocking the effects of the hormone epinephrine, also known as adrenaline. Beta blockers cause your heart to beat more slowly and with less force, which lowers the blood pressure. Beta blockers also help open up your veins and arteries to improve blood flow. So this kind of shows on like a biochemical level how beta blockers work. So as we can see here, the receptor takes in what's been released from the beta blocker itself on the biochemical level. And we can see here that beta blockers slow the SA node, which initiates heartbeat. And this then allows the ventricle to fill completely and lowers the heart workload. So overall, this is how beta blockers work to dilate the arteries and lower blood pressure. Okay, so review systems. So when we're looking at this patient, we know that they are presenting with prolonged chest pain, shortness of breath, abdominal pressure, a blood pressure of 100/60, and a heart rate of 100 beats per minute. And then this is their blood test, right? So we talked about how the cholesterols differ. If I remember right, LDL is good, HDL is bad. So we can see that HDL was low and LDL was kind of high. That's pretty good. And so in general, HDL is good. So HDL, you want it to be 60 or above. So we can see here that the patient's cholesterol level is at 35 mg. So that's lower than 60. And then in terms of LDL, which is bad cholesterol, it should be less than 100. So we can see that their LDL or bad cholesterol is higher than 100. And because of this, LDL can then lead to the development of atherosclerosis caused by plaque buildup in the arteries. And we know that leads to heart attack. So I kind of spoiled it, but that is what happens in the end with this patient. So when we're looking at the physical examination of this patient, the first step that was used is pulling up a electrocardiogram. I don't think I said this, but this case study itself was published as a research paper, so this is real. Okay. And so from the electrocardiogram, they were able to see that the heart is unable to normally pump blood, and that the patient specifically had left ventricular dysfunction and tissue damage leading to skipped beats. Okay. So this is how a electrocardiogram or EKG works. So as you can see, for each I guess, type of heart movement and pump, there is a specific line that kind of denotes how that occurred. Okay. So then moving on, this is a electrocardiogram or EKG. And so what popped up was I think they had the resolution phase that popped up. But these are the different types of phases that pop up when physicians try to consider how your heart is doing. And if the patient had a heart attack or a myocardial infarction, this is usually the type of phases that will pop up. So if they have a hyperacute phase, this is what will pop up: fully evolved, resolution, and stabilized. So I think hyperacute is when the heart attack happens, and then fully evolved is following it, resolution is after, and then stabilized is right after. So I think that usually happens after, they monitor the patient as well. Yeah, and then when we're looking at the EKG, we can see here that there are different nodes. So there's the P node, Q, R, S, and T. So each of these relate to the contraction and relaxation patterns of the heart. All right, so I kind of spoiled it in the beginning, but the patient did have a heart attack or myocardial infarction. In this case, it was a myocardial ischemia. And in terms of immediate treatment, the patient was treated with aspirin and had a angioplasty and stent procedure. And in terms of prolonged treatment, the patient is advised to have a healthier diet, have daily exercise, continue medications, and manage their electrolyte balance and their stress as well. So yeah, if you guys don't know, an angioplasty is a special type of tubing that is attached to a deflated balloon that's threaded up to the coronary arteries. With this procedure, it essentially opens up the arteries to allow for better blood flow after a heart attack. And then with the stent procedure, essentially there's a wire mesh tube, which is a stent, and that's used to open up an artery during the angioplasty. In some cases, that wire mesh is left in the artery to make sure that it's kept open. And then, yeah. And then in terms of the heart attack, arteriosclerosis is the most common cause of the myocardial ischemia. The plaques that develop in arteriosclerosis can rupture, which then causes a blood clot, and the clot might block an artery, which then leads to sudden and severe myocardial ischemia, resulting in a heart attack. So that's how that happens. Okay, and so this is a quick video, and I'm done after this. But this is essentially talking about what is the angioplasty and stent procedure for people recovering from a heart attack.
The heart is a pump that circulates blood to your lungs and the rest of your body. It lies in the center of your chest, between your lungs. The heart is a pump that circulates blood to your lungs and the rest of your body. It lies in the center of your chest, between your lungs. The network of blood vessels that branch over the surface of the heart are the coronary arteries. The coronary arteries supply the heart with blood. Over time, fatty deposits can build up and form a plaque or atheroma on the artery lining. This can cause the arteries to narrow and prevent the heart from getting the blood and oxygen supplies it needs. This causes pain in the chest called angina, especially during exertion or stress. Angioplasty can open the narrowed arteries so blood can flow more easily to the heart. Angioplasty is normally carried out under local anesthetic to numb the area where the catheter is inserted. You will stay awake during the procedure. A small cut will be made in your groin, and a catheter will be passed up through an artery to your heart. Your surgeon will use X-ray images to guide the catheter and direct it to the narrowed artery. Here we show the path of the catheter to your heart. A guide wire with a deflated balloon and stent at the tip is passed through the catheter. When the guide wire reaches the narrowed section of your artery, the balloon will inflate to open up the artery and the stent. The stent is left in place to keep the artery open, and the balloon is deflated and removed. Sometimes the stent is coated with medicines to reduce the risk of your artery narrowing again. Here we show the blood flowing through the artery with the stent in place. The catheter is then removed. A dressing will be placed over the incision.
Cool. So hopefully that was kind of cool. Yeah, so these are the references. So like I said, I referred to research papers for what was covered in this. Yeah, if you guys have any questions, I can answer them. If you want to reach out, I'm setting up a little side gig for like kind of like mentoring, but it's gonna be more of like a blog. So if you want to email me or reach out, you can email me here. And yeah, I'm here to answer questions.
Thank you so much. That was really informative. And if any of you have questions, you can go ahead and drop it in the chat. For now, I'll go over some questions that were put in the Google form. For one, what extracurriculars did you do in high school to prepare for pre-med?
I would say like the most important thing you can do in high school is volunteer in a hospital. I volunteered at my local hospital, and I feel like that really showed me like the reality of how working in a hospital is. So I would say that, and then I would say like starting an initiative while you're in high school. That kind of helps you when you're applying to college, but it also helps you because, you're pursuing something that you're passionate about. So yeah, I would say that.
Okay. And how did you decide that this was the path you wanted to take and was interested in?
Yeah, I kind of feel like that was forced upon me just because growing up, my parents and like I had a lot of health problems too. So, I kind of had to be that person in my family to like teach them, why was this happening and like, what do we do now, Because like after like a heart attack with my dad, it was really hard recovering from it. And it kind of it affected all of us because like our diets changed and we were like, oh my God, what if it happens to us too? So I feel like it was kind of forced on me.
I see.
Yeah.
And another question is, how can I find medical programs or opportunities to participate in relating to patient experience?
Yeah, so in terms of patient experience, I would say again, like volunteer in a hospital. Even if you don't want to volunteer in a hospital, try volunteering at a free clinic. I feel like with free clinics, you also get more exposure to people of minority groups. Just because, sometimes people don't have access to health insurance. And I think that's a valuable experience to have.
And what studying advice would you give to those who struggle with math and science?
Study advice. hold on, let me also like stop sharing. So study advice, I would say you learn as you go. And it's kind of, I feel like with me, I like kind of seeing my growth trend in terms of like, like quizzes and like, I guess mini tests, because I feel like with each quiz you take, you kind of have a better understanding of like, okay, what information do I really know and what information do I need to review? So I would say the best thing to do is like learn how you learn because everyone learns differently. And kind of consider different strategies that might work for yourself.
Okay. And would you recommend anything that 8th or 9th grade students should be learning now?
8th or 9th. Look at you guys are so young. I'd say 8th or 9th. So for 8th graders, you guys are in middle school. I would say for middle schoolers, I would say again, like reading up on what you can, like reading more books, trying to educate yourself. I know that there are a lot of like, I think you guys study the basics of bio in middle school, so you guys can do that. In terms of 9th graders, so you're starting high school. I would say for the 9th graders, kind of consider what AP classes you want to take. So I know like what AP Bio it's out there, but I think you guys take it after. But consider what you want to take in high school. Because if you have a good foundation in high school, you can carry that on into college.
All right. And how would you recommend expanding an initiative that a student has started?
Yeah, I guess in terms of expanding an initiative, being able to work in a team is really important. Uh, because in an initiative, it is about like your vision, but it's also about working with other people and making sure that they can also do what they're passionate about, right? So really emphasize the teamwork and see how everyone can kind of I guess like do their own thing.
All right. And since I don't see any more questions in the chat, I think that should be it. And I have not heard anything from Carol, so I'm assuming that she won't be attending today.
Yeah.
But thank you so much for your presentation. It was really useful and informative, and we really appreciate it.
Yeah, hopefully you guys learned a lot today. That was my goal. And yeah, if you ever want to reach out, feel free to email me.
Thank you so much. And all attendees, if you have a different name on the Zoom right now than what you used to register, would you mind putting that in the chat? I think there was only one person I saw with a different name, but I don't think they're here anymore. Okay, so if everyone is good, that should be the end of our event today. Thank you everyone for attending. We're planning to maybe have another one since there was another speaker that could have came today and also another one. So we have 2 other speakers, so maybe we'll have a different date for that. And we'll be sure to keep you posted. And yeah, thank you for attending. I hope that this was really helpful for you guys and that you learned a lot and got some good advice. And I hope you all have a great day.
Bye, everybody.
Bye.